Good morning, 5th grade students. I'm Dr. Doaa El-Shafey, Assistant Professor, Obstetrics and Gynecology Department. Today we'll be discussing a very important topic, which is uterine leiomyomata. To mention, this topic is very important, being the commonest benign tumor of the female genital organ. And if you're going to if you're going to practice obstetrics and gynecology, you will inevitably face conditions with uterine fibroids. Uterine fibroids usually is the commonest name, but leiomyomata is the most correct name because that's the name describing the origin of the tumor, being a benign tumor of the smooth muscles. And from this image you can see that there is diversity in the size, in the number, and thus in the presentation of such cases. If you're going to take an overview about uterine leiomyomata, you should know that you should be aware that it's the commonest benign tumor of the female genital organ. It usually arises from a single muscle cell within the myometrium. They're almost detectable in about 20% of the women in the childbearing period, and up to 50% of the uteri examined at autopsy, which means that they may pass over, the female may pass unnoticed all through her reproductive life, being unnoticed, being not diagnosed, and they're just accidentally discovered or seen when doing an autopsy examination. They usually grow in a very slowly progressive course over many years, and that's very important in the clinical progress of this condition. They have a very low malignant potential, thus they pass unnoticed and in the vast majority of the conditions, and they're usually diagnosed on 3 conditions: if they're accidentally discovered and during routine examination, if they're producing symptoms, and if they're reaching a very large size. The risk factors, there are several risk factors. There are several risk factors for the presence of leiomyomata, most common of which being that the females that are nulliparous or of low parity are more prone, those who belong to dark races, obesity, those who belong to families of positive family history of leiomyomata. But there are also common associated conditions. The commonly associated conditions are usually related to the hyperestrogenic state, the presence of follicular ovarian cysts, the presence of endometriosis and adenomyosis, the presence of concomitant endometrial hyperplasia, but very rarely endometrial carcinoma. And these commonly associated conditions can be attributed to the high estrogenic state that is present within the tumor. The etiology of fibroids is not known, okay, but it has been attributed to the hyperestrogenic state being only appearing in the childbearing period of life. It's not just, we don't mean here it's being diagnosed, but we mean that it appears for the first time in the childbearing period of life. There are no tumors to develop, and there is no de novo tumors to develop before puberty, neither before puberty nor after menopause. There is a common associated with endometrial hyperplasia, and it has been seen that they usually increase in size during pregnancy if the patient is receiving pills, estrogen treatment, and they undergo some sort of atrophy after menopause. All these factors highlighted that this tumor is estrogen dependent and related to the hyperestrogenic state. There's the other factors that may be attributed to the etiology, although we don't have a definitive factor for these, but may be attributed to some growth factors, epidermal growth factor, growth inhibiting factor, and some cytogenetic abnormalities, and that's what may explain that these tumors can run in families, and there is a very strong association with a positive family history of fibroids. The pathology, we're going to discuss the size, the shape, the number, the consistency, the cut section of these tumors. Besides, they may affect any part of the uterus, so far that we're having muscle fibers. So if we can divide the uterus into the body, the cervix, the body of the uterus, or the corpus of the uterus, the cervix, or even the broad ligament, so that these 3 parts are affected, but most commonly in the uterine body itself, which means corporeal in almost 96% of the cases, less commonly up to 4% in the cervical fibroid, and the most rare condition or the least common condition in the broad ligament, less than 1%. The types, there is a great diversity of the types of myoma according to the site of origin or the starting point: interstitial, subserous, submucous, or even pedunculated. Interstitial myomata means that the fibroid starts within the muscle fibers itself, interstitial, included in the myometrium itself, and some of which they remain interstitial myomata, but some of which they proceed later either to subserous or submucous myoma according to the direction of growth. The subserous myoma is the tumor that projects from the outer surface, covered with peritoneum. That's the tumor projecting on the outer surface of the uterus. The submucous myoma, that's the tumor that projects into the uterine cavity and that's covered with endometrium. So there is a difference in the direction between subserous and submucous myoma and the covering layer. They're as if they're opposing. If we can imagine that each of them started as intramural myoma or interstitial myoma, but the subserous is directed outside the uterus and covered with the serosa or the peritoneum. The submucous myomata is directed or projecting into the endometrial cavity and covered by the endometrial lining, and each of which can be later on proceed to a pedunculated type, for example a pedunculated subserous myoma or a submucous fibroid polyp. The size there's a variable size. It can be seedlings less than 1 centimeter and may reach a huge size occupying the abdomen. As for the shape, almost all of which are rounded or spherical in shape. The number still can vary, minimal number, or can reach a huge number. But if we're talking of fibroid polyps, that usually submucous fibroid polyp are single, and the cervical and the broad ligament fibroids are usually single. The consistency, they are firm in consistency, and that's the rule, that the fibroids are firm in consistency unless we're having a complication or some sort of degeneration that we will discuss in detail later. If you're going to take a cut section, okay, or the gross appearance of the fibroids, we can see that the fibroid usually will exhibit a paler appearance than the normal myometrium. Okay, the surrounding myometrium will be appearing much more pink, but the fibroid will be paler. There is a whirly appearance, and the whirly appearance due to the compression of the fibrous tissue and the interlacing muscle fibers. There is a pseudo capsule, false capsule, which means that there is not a real capsule, but as their appearance, they appear as if they are capsulated because of the compression of the normal surrounding myometrium, and the blood vessels line the capsule, which means that the most vascular area is in the periphery, and in the center that's the least vascular. As for the microscopic picture, there are smooth muscle fibers arranged in bundles together with spindle-shaped smooth muscle fibers and fibroblasts. The fibers are elongated with spindle-shaped nuclei, and if you're going to stain them by Van Gison stain, which colors the muscle cells as yellow and the fibrous tissue cells as pink. There are several pathological changes which will occur in fibroid. Here summarized to have 10 to 8 changes: atrophy, hyaline degeneration, cystic degeneration, fatty degeneration, calcification, red degeneration, necrosis, and infection. Why are we concerned about the pathological changes? Because we have mentioned that these usually the fibroids they follow the rules. They're firm in consistency so far that they're small. They do not produce any symptoms unless we're having some sort of degeneration, pathological changes, or complication. So these pathological changes, they usually affect the clinical presentation and the nature of the fibroids. That's why we do care about studying them. What's meant by atrophy? Atrophy means that there is shrinkage or diminution relative diminution in the size of the fibroid, and that usually occurs commonly in the menopause, okay, or during the perpurium, or even on long-term GnRH analog. Why? Because it is related, the diminution in the size, the decrease in the size of the fibroid, and the atrophy is related that there has been a drop in the estrogen status. There had been a secondary to estrogen deficiency. So commonly it occurs in the menopause and may occur relatively during perpurium, because there will be a relative drop in the estrogen status from the high estrogen status encountered during pregnancy. And if the patient is receiving long-term treatment with GnRH analog, which will lead to downregulation, pituitary downregulation, and hypoestrogenic state. It won't affect the clinical picture because simply it occurs silently. That's a silent change and it's painless. It will just lead to diminution of the size. What about the second one? Is hyaline degeneration. And hyaline degeneration, that's the commonest change that occurs during the childbearing period, and we have mentioned that the blood supply in fibroids is coming from the periphery, so the hyaline degeneration, it occurs in the center of the tumor because that's the area of the least vascularity. The point is microscopically the whirly appearance is lost and the tumor is replaced by a homogeneous structureless material, and that clinically would affect that the tumor becomes more soft in consistency and is associated with mild to moderate dull aching pain due to the relative ischemia, and the hyaline material itself is slightly irritant, so that's why explains that there is some sort of dull aching pain. The cystic degeneration, it also occurs in the center because it occurs secondary or following the hyaline degeneration, and it's rare, but it leads in a more aggravated condition at which there is absorption of the liquefied hyaline material. So microscopically the cavity will be lined by remnants of unabsorbed hyaline material, and clinically the tumor will become more soft or even cystic, and may be presenting with more dull aching pain. The fourth degeneration that may be encountered is the fatty degeneration, and that means deposition of fat within the muscle cells, and it's just a precursor of calcification. What about calcification? Calcification is the deposition of calcium phosphate and calcium carbonate within the muscle fibers, and it occurs either peripherally or diffuse. If it's just affecting the peripheral, the boundaries of the tumor, it has been described as an eggshell, as if it mimics or it's similar to the shell of an egg. But if it's diffuse, affecting the whole tumor, it has been described as a womb stone. Womb means uterus, so as if we're having a stone in the uterus, like renal stone or calcular stone, that's a womb stone. It's detected by either plain X-ray or ultrasound. By ultrasound you will find a hyperechoic area, and X-ray as if it's a stone, as if it's a calcified area, and it's very common after menopause. Usually this change occurs after menopause, and it's very commonly encountered during the menopausal period. Then comes necrosis. Necrosis usually occurs whenever we're having a very poor blood supply. There's interruption in the blood supply, and that's why it occurs at the tip of a submucous fibroid polyp, or if there is a torsion of a pedunculated subserous myoma. It affects the area of the least vascularity, areas of ischemia, and usually it occurs at the tip of a polyp or pedunculated myoma that has torsion occurred. And on top, infection may occur at the same condition, either the tip of a submucous fibroid polyp projecting into the cavity. It's commonly to occur when there is a rapid change in the size. For example, during purpurium, after pregnancy there is diminution in the size, so it may be very common to occur during purpurium, or if there is a spread from a nearby infected organ, as appendicitis. The red degeneration or necrobiosis, or previously called Carney's degeneration, that's a very important degeneration for you to understand. First, it is the commonest to occur during pregnancy. It almost occurs during pregnancy, and very extremely rare to occur in non-pregnant ladies. Why especially during pregnancy? Because during pregnancy there is a rapid growth of the tumor, as if the tumor is outgrowing its blood supply. During pregnancy it outgrows its blood supply, so there is kink of the blood vessels, and the kink of the blood vessels may lead to some sort of stagnation and predispose to thrombosis. And in the other condition, in the other side, during pregnancy there is increase in the fibrinogen level. It may reach 400 to 600 mg/%, so there is a tendency to increase to a coagulable state, which adds more to the increased thrombosis. So whenever we're having increased thrombosis, the thrombosis will lead to ischemia, okay, and then release of a lipoid toxin. This toxin will lead to intravascular hemolysis, and there is diffusion of the blood pigments. That's what gives the tumor its red color. Clinically, the myoma will become enlarged, will become tender pain due to the relative ischemia, and the patient may be presenting with acute pelvic pain and mild pyrexia. Mild pyrexia because of the diffuse of the blood pigments. Are the hemolysis of the RBCs, and the pigments will activate the heat regulatory center. They are pyrogenic. For the patient, there is tenderness, there is enlargement of the tumor, there is acute pelvic pain during pregnancy, and mild fever. The role of treatment here is conservative. Mainly is conservative. You have the patient to be rest and analgesics. Usually in such conditions there is no place for surgical intervention. The main line is conservative, fluids, rest and analgesics. Complications of leiomyoma. The complications of leiomyoma commonly encountered are torsion, if you're having torsion, or rupture or incarceration. Torsion, it's not common to have a torsion of a huge myoma. It's usually if there is a pedicle or a pedunculated. If you're having a pedicle or a pedunculated subserous myoma, that's much more common torsion, but it's extremely rare to have torsion of the whole uterus. Rupture is of a surface vein of a subserous myoma, which will present with internal hemorrhage, intraperitoneal hemorrhage. Incarceration or impaction, and usually this occurs if there is a huge myoma, especially in the Douglas pouch and especially during pregnancy. These are images of to highlight the first one is calcification, and see that that's what meant by womb stone. It's all diffusely white in color. The red degeneration of fibroid in a gravid uterus, to emphasize the fact that red degeneration occurs mostly during pregnancy, and it becomes red in color due to the diffusion of the lipoid toxin and the blood pigments, which stains the tumor red. Sloughing of a fibroid. Here you can see here that there has been a torsion of the polyp, which leading to necrosis and sloughing of a fibroid polyp, and rarely inversion of a uterus due to prolapse of a large submucous fibroid polyp. That's another image. Cystic degeneration. We can see that the hyaline material, there is a remnants of the hyaline material in the center of the tumor. It becomes more cystic. Incarceration or impaction of a huge tumor in the Douglas pouch. It may affect the course of labor, leading to dystocia. Incarcerated fibroid leading to dystocia. It will affect the course of labor, and it will prevent or handicap the fetal descent during labor. There is a lost entity that's known as malignant change in fibroids. That's a very common question. Whenever the patient hears that she's having a tumor, what pops out in her mind, I'm having a malignant tumor. To reassure you that the incidence of leiomyosarcoma within myomas is extremely rare. We're speaking of an incidence of about 0.2 to 0.5%. And so the rule in my fibroids is that it's malignant, it's benign till proved otherwise. But when shall we suspect malignancy? We shall suspect malignancy. The clinician should suspect malignancy whenever facing these conditions. If it first appears or increasing in size during menopause. We have mentioned that during menopause, either the tumor will be static or will be slight diminution in size, atrophy, due to the relative drop and the decrease in the estrogenic state. So it's not appropriate to first appear or to increase in size during the menopause. If the patient is presenting with postmenopausal bleeding, I have to consider the concomitant malignant changes as well. If there is rapid growth, even without evidence of degeneration, or if there is rapid recurrence after surgical excision. We have mentioned that this tumor, usually the benign tumor, is of a very slowly progressive course over years or years. But if in a period of months I have noticed that there is rapid growth or rapid recurrence after the surgical excision, all this would alarm me of a possible malignant change. The gross appearance during surgery, that we'll find that the tumor, there's areas of more friable, that there are more areas of hemorrhage and necrosis. The color is not that paler than the surroundings, and the most important of which, that the pseudocapsule is not present. I cannot delineate boundaries for this tumor, as if it's invading the surroundings, and there is difficult inoculation of the tumor. Microscopically, and that's the definitive diagnosis, that we'll find a mitotic figure, more than 10 mitotic figures per high power field, and there's cellular asphyxia and necrosis, and that's the pathological examination is the final and the definitive diagnosis for leiomyosarcoma. What about the effect on the pelvic organs? The fibroids usually affect the uterus. It affects the uterus and the nearby organs, commonly the renal system. If you're having it, may lead to symmetrical or asymmetrical uterine enlargement according to the site and the size. It may distort the endometrial cavity in case of a submucous myoma or a submucous fibroid polyp. If it's a very large myoma, it may lead to displacement of the uterine position. I think there is increase in the vascularity and the venous congestion, and this what explains the pelvic heaviness and the pain. Even if it's protruding anteriorly, it may lead to pressure on the urinary bladder, leading to frequency of micturition. If it's a large cervical myoma, may overstretch the urethra and make compression, leading to retention of urine. If it's a large cervical or a broad ligamentary myoma, may end up in hydroureter and hydronephrosis, but actually these two, the retention of urine, hydroureter and hydronephrosis, won't occur except if we're having cervical or broad ligamentary large myomas, not the small myomas. The clinical picture of leiomyomata, you have to understand that the clinical picture of leiomyomata is a collective of all the symptomatology of gynecology. Whenever you think of any gynecological symptom, you can encounter it in myoma. The age where it's more prevalent at the range of 35 years, although that we have mentioned that you can discover it before or after that. The parity, though, it's more common in nulliparous women and those of low parity. The symptoms, we're having all symptoms, starting that we don't have any symptoms at all, and you're facing all the symptoms, all the gynecological symptoms. No symptoms, and that's very common, that most fibroids, the vast majority of fibroids, they do not present with any symptoms, especially if they are small or subserous, and they're accidentally discovered during the pelvic examination or better by pelvic ultrasound. Symptomatizing fibroids, whenever they're large, they're complicated, or in a certain size that leads to pressure symptoms or bleeding symptoms. Usually it occurs whenever we're having a large size fibroid, especially the interstitial and the submucous myomas, and they're discovered by examination or by ultrasound in relation to the presenting symptoms. What symptoms that we may be encountered? All the gynecological symptoms, menstrual symptoms, irregularity in the menstrual pattern or bleeding symptoms, bleeding, pain, pressure symptoms, infertility, leukorrhea, abdominal mass, pregnancy complications, and even general symptoms of anemia, affecting the patient's general condition. To start with, the most common presentation is the menstrual symptoms, and it's very important that being a benign tumor, it respects the normal menstrual pattern. The rule of fibroids to respect the normal menstrual pattern. So menorrhagia is the commonest symptom in fibroids, especially if it's a submucous myoma or even multiple intramural interstitial myomas. Why would it's very logic that a submucous myoma, a myoma protruding inside the cavity, will lead to menorrhagia. But why would the intramural or interstitial myomas lead to menorrhagia? Especially because these myomas will lead to the increase of the surface area of the endometrium, so there is more shedding of larger surface area of the endometrium. There is mechanical interference with the uterine contractions. There is an associated hyperestrogenic state, and there is increase in the vascularity, the myometrial vascularity. Metrorrhagia occurs, so we have fibroids respect the normal menstrual pattern and almost the usual presentation or the logic presentation to have menorrhagia. Menorrhagia is that the patient would present with heavy, regular but heavy menses. What about metrorrhagia? Metrorrhagia is irregular menstrual bleeding. Irregular menstrual bleeding not respecting the usual patient's menstrual pattern. Usually this occurs if there is infection, if there is sloughing in a fibroid polyp, and if I'm having the start of malignant changes. This would lead to metrorrhagia. Then, what about pain? Fibroids are usually painless. They do not present with any sort of pain unless we're having a complication or a very large size. And the pain that may be encountered, again, all types of pain. It may be dull aching pain, and dull aching pain that occurs in cases of hyaline degeneration, or even if sarcomatous changes occur if there is an infection of a submucous fibroid polyp. Sometimes it may present with an acute abdominal pain. An acute abdominal pain is in one of two conditions: red degeneration that usually occurs during pregnancy, or if there is a torsion of the truncated subserous myoma. There is colicky pelvic pain, and colicky pelvic pain if I'm having a small submucous fibroid polyp and there is a attempt of extrusion, as if it's like abortion, the uterus wants to expel the submucous fibroid polyp through the cervix, so this will lead to colicky pelvic pain. Very common to have dysmenorrhea, whether congestive or spasmodic dysmenorrhea secondary to the pelvic congestion, and if there is submucous myoma or there is a polyp, or even secondary to the pelvic congestion in general. And there may be pain due to a common association with a concomitant condition, endometriosis for example. So the rule is that having a painless If it's a painless condition, unless I'm having a complication, it may exhibit all types of pain: dull aching pain, acute pain, colicky pain, congestive dysmenorrhea, spasmodic dysmenorrhea, or even the pain encountered in conditions such as endometriosis. There are also pressure symptoms. The pressure symptoms in case of large myomas. If it is anterior myoma, it will lead to compression of the urinary bladder, which will lead to frequency of maturation and dysuria. And sometimes this presentation is not just related to the size of the myoma; it's attributed to the secondary to the pelvic congestion. If it's large cervical or broad ligamentary myoma, may compress the urethra and lead the urethra of the urethra and lead to retention of urine. The compression and the irritation of the pelvic nerves may lead to referred back pain and thigh pain. Infertility, it's only encountered in 5 to 10% of the cases, and even a less percentage as a sole or as a solitary cause of infertility, even less than 3%. And the mechanism attributed may be that it's leading to tubal obstruction. If it's bilateral corneal myoma, maybe it interferes. If it's a cervical myoma, with the sperm motility, maybe it interferes with the implantation. But it's very common, or it's not to be mentioned, that large myomas and the submucous myomas, they definitely interfere with the infertility and the implantation, and lead to complications with the IVF management. Other symptoms, yes, we have other symptoms. Pregnancy complications, all pregnancy complications may occur: recurrent pregnancy loss, preterm labor, dysfunctional labor, malpresentation, obstructed labor, or even postpartum hemorrhage. Recurrent pregnancy loss, if it's related to the implantation, if it's a submucous myoma, or if it's a huge subserous myoma or intramural myoma more than 5 centimeters. Preterm labor, still, if it's a larger myoma. Dysfunctional labor, if there is incarceration or impaction in the Douglas pouch during the course of labor. Distorting the uterine cavity, the shape of the uterine cavity, it's very common to be associated with malpresentation. Even may lead, if it's a huge myoma, may lead to obstructed labor. Postpartum hemorrhage, because it interferes because of the increase of the uterine vascularity and interferes with the uterine contraction in the postpartum period. So it is attributed to almost all pregnancy complications. Leukorrhea, the increase in the vaginal discharge, attributed either to infection or due to the pelvic congestion. Progressive abdominal enlargement, in case of large myomas, will lead to progressive abdominal enlargement with or without pressure symptoms. The signs on examination: what would I face when I'm doing an examination? It differs according to the site and to the size, and not to mention that it may pass unnoticed if it's a small myoma. If we're doing an abdominal examination, the large myomas will be felt abdominally if the uterus enlarges above the pelvic brim, and either symmetrical or asymmetrical enlargement. If it's symmetrical, it will be felt as a central firm mass with a bossy irregular contour or symmetrical enlargement of the uterus. Usually, if it's not complicated, it would be non-tender and of limited mobility. Why of it limited mobility? Because it is attached to it is within the uterus. It is as one mass and dull on percussion. It's very important that being a pelvic abdominal mass, that the upper border can be felt, but we cannot delineate at the lower border. You cannot insinuate your hand below the lower border of the mass, because it's a pelvic abdominal mass. It's a mass. It's not a mass that arises from the abdomen and progresses to the pelvis. It's the other way around. It's a mass that arises from the pelvis and enlarges and descends towards the abdominal cavity. So that's why you cannot insinuate your hand below its lower border, and that's why when you're doing an examination, you mention that this is a pelvic abdominal mass. Local examination: we pass through the steps of the local examination systematically by the PV examination, the bimanual, and the speculum. The PV examination: inserting 2 fingers to palpate the cervical os and the vaginal walls, you may detect a cervical myoma, a submucous fibroid polyp. The bimanual examination is putting your hands in the vagina, and concomitantly you put another hand on the abdomen and the pelvis and make some sort of compression to detect the size of the uterus, the direction, if there are any masses, if there is tenderness or pain, the consistency, and the mobility. And in case of fibroids, you will detect that there is uterine enlargement, firm. Sometimes you may have, if there is symmetrical enlargement, it would be symmetrical to diffuse enlargement, but if irregular, you can feel bossy contour. It's not tender, and there is restricted mobility. The speculum examination, you insert a speculum inside the vagina to inspect, to see the cervical os and the vaginal walls. You may visualize cervical myoma, submucous fibroid polyp protruding through the cervix. The differential diagnosis, it can be differentiated from tremendous conditions. For example, if it's a large fibroid, it should be differentiated from other causes of pelvic abdominal swelling. If it's a submucous fibroid, it should be differentiated from a submucous fibroid or an interstitial myoma, other causes of symmetrical enlargement of the uterus, especially pregnancy adenomyosis. If it's a calcified myoma, from calcified shallow plain X-ray, the most common of which is missed IOD. If it's a fibroid polyp, it should be differentiated from any mass protruding from the cervical uteri, polyp, fibroid polyp, endometrial polyp, malignant polyp, all these conditions. The special investigations, we can advent all forms of investigations with fibroids: ultrasound, CT, scan and MRI, hysterosalpingography, or even endoscopy. But the most important, we should understand that the gold standard, whether for diagnosis or for screening of these conditions, is the ultrasound, whether a transabdominal or a transvaginal ultrasound. The transabdominal ultrasound will delineate large myomas that are protruding or descending into the abdominal cavity. The value of the transvaginal ultrasound, you can delineate small myomas, submucous myomas. You can detect, you will check the condition of the cervix, if it's affected or not, and you can examine the condition of the ovaries. What's meant by CIS? CIS is the abbreviation of what's known as saline infusion sonography. The saline infusion sonography, that's a procedure by which you're doing an ultrasound while you're injecting a saline into the uterine cavity. The uterine cavity is a potential space. Normally it's closed. The space, the anterior and the posterior wall are collapsing upon each other. They are only distended if you're having a pathological lesion inside, and you can delineate this pathological lesion by injecting a saline to extend the cavity, to make a distance between the anterior and posterior wall, and delineate if there is any pathological and intracavitary pathological lesion. And this is the injection of the saline is done concomitantly with the ultrasound to delineate the cavity, as if you're doing a hysteroscopy or as if you're doing a hysterosalpingogram. The CT or the MRI that's not routine, but that would be if you're suspecting malignancy, if you want to, if it's a huge mass and you want to delineate its relation to the other abdominal and pelvic organs, but that's not the routine. That would be just prescribed for certain conditions. Hysterosalpingography, the role of the hysterosalpingography is to delineate the uterine cavity. So you would only need hysterosalpingography to detect a submucous myoma or a submucous fibroid polyp, or in the cases of seeking fertility, to delineate the concomitant condition of the tubal patency condition. If she is a patient who is seeking fertility and she's going to do an operation, so you would like to know the condition, the tubal patency condition, beforehand, before proceeding to any surgery. Endoscopy, either hysteroscopy or laparoscopy. The hysteroscopy will delineate the myomas inside or within the uterine cavity, submucous myoma or submucous fibroid polyp. The other way around in laparoscopy would detect the subserous myomas, because the hysteroscopy you are viewing the uterine cavity from inside, but the laparoscopy you are viewing the uterus, the outer surface of the uterus, because the outer and its relation to the pelvic organ. So you are viewing the uterus from the outside. That's an image collecting all the diagnostic material, all the diagnostic procedures. An abdominal ultrasound, you're viewing with an abdominal probe. The vaginal ultrasound, you're putting the ultrasound probe in the vagina. The hysteroscope, you enter through the uterine cavity and making a distension, using a distension medium to distend the uterine cavity and delineate what's in the uterine cavity. The laparoscope, you are distending the abdominal cavity and you're viewing the uterus from the outside. So the hysteroscope for submucous myomas, the laparoscope for subserous myomas, the abdominal ultrasound and the transvaginal ultrasound for screening, and the abdominal would be better for the large myomas, the vaginal for the small intramural, subserous or submucous myomas, and as well assess the condition of the cervix and the ovaries. That's an ultrasound image of, these are different ultrasound images of the fibroids. They're usually, we have a pathognomonic appearance, as if it's a ball. That's quite different from the echogenicity of the other surrounding uterine structures. You can delineate it, and there's a pseudocapsule. What about the management? The lines of management of fibroid, we have 5 lines of management. Conservative approach, that means we'll do nothing, you'll just regular follow-up without any treatment. Medical treatment if there are associated symptoms. Okay, hormonal treatment to control the amount of bleeding and the size of leiomyomas. Recently there has been a minimal invasive procedure in selected cases to avoid the surgical approach, but the definitive surgical treatment is either myomectomy or hysterectomy, and each of which through different routes, laparotomy, laparoscopy, or hysteroscopy, or through the vaginal route. The conservative approach, what do we mean by the conservative approach? The conservative approach is that we're doing nothing. Okay, we just do nothing. We're just doing a periodic follow-up every 6 months and 12 months for the asymptomatic conditions or those who are nearly entering the menopause and need nothing. Why are we doing this? We are doing this to make sure that there is no increase in the size, there are no any changes, there are no any complications, there are no risk of malignant changes. And usually that's done during pregnancy. During cesarean section, whenever the myomas, usually we do not remove the myomas during cesarean section unless if there is a complication, if there is torsion, if there is infection, if it's intervening with the site of uterine incision. Okay, and not to mention that conservative approach is abundant whenever the myoma reaches a large size or results in severe uncontrollable symptoms such as severe pain or pressure symptoms or severe bleeding. So we are doing the conservative approach, but it is abundant whenever we find new symptoms or complications. The medical treatment together with the conservative approach or even the surgical approach or whenever with other lines of management to control the bleeding and the pain through the non-steroidal anti-inflammatory drugs, the hemostatic drugs, and the venotonic drugs. The non-steroidal anti-inflammatory drugs to control the pain and bleeding by inhibiting the prostaglandin synthesis, the hemostatic drugs as tranexamic acid that acts as a fibrinolytic agent to control the bleeding, and the venotonic drugs such as Daflan to improve the vascular tone and decrease the pelvic congestion. The medical treatment, it has no place in case if you're having severe bleeding or if the condition is affecting the patient's general condition and leading to severe anemia. In such conditions, you may need blood transfusion or parenteral iron therapy before proceeding to more definitive treatment. The hormonal treatment is to minimize the menstrual blood flow, regulate withdrawal bleeding, or even to induce secondary amenorrhea. For using gestogens, gestogens will to minimize the amount of bleeding and induce regular cycles every 28 days and to minimize the pain as well. So its value of the gestogens is to regulate the cycles and minimize the bleeding and the pain. The GnRH analogues, they induce a state of severe estrogen deficiency, so they lead to secondary amenorrhea, may lead to minimal reduction in the size and the vascularity of the myoma, but you have to understand that the hormonal treatment, that's not a definitive treatment and that's not a permanent treatment. It's only a temporary treatment because it's only a temporary treatment. Usually we advance this GnRH analog in particular as a temporary treatment being expensive, and if we use it as a long-term management will lead to other complications, will lead to menopausal symptoms, and may affect the bone density and the bone integrity, and whenever you stop it, the leiomyomas will return to the pre-treatment size. So it cannot be used as a long-term treatment. It's just a temporary treatment. You can use it, for example, to correct the anemia, to increase the hemoglobin level, just as a pre-operative preparation before you proceed to more definitive treatment. The minimally invasive procedures, these are new modalities emerging in the gynecological practice for those who are surgically unfit or those who differ from the surgical management. We have what's known as uterine artery embolization, laparoscopic myolysis, MRI guided high frequency ultrasound. What's uterine artery embolization? The uterine artery embolization is that's a radiological interventional procedure. That means a trained radiologist by which there is an injection of a foam material, a gel foam material, through a catheter inserted through the femoral artery to reach the uterine artery or its branches, as if we're occluding the uterine artery by gel foam material and inducing a state of ischemia for the tumor to shrink in size. Okay. The laparoscopic myolysis, that's a procedure using laparoscopic myolysis using laser or coagulation current or cryomyolysis, but it's only of benefit in small and sub-serous myomas and usually non-symptomatizing. So there is a question why to use it from the start, because these conditions we would advent conservative management, we would do nothing. The MRI guided high frequency ultrasound, that's another modality using an ultrasound generated heat to cause cell death and guided by the MRI to detect it, to delineate the site and direct the ultrasound beam to the myoma to produce some sort of protein denaturation. All these procedures are recent conditions. They're not the rule, but they are proceeded in those who defer to surgery, and still we are in need of further data about them. The surgical management is either hysterectomy or myomectomy. Hysterectomy is to remove the whole uterus and the fibroids in total, and that's the only definitive treatment for fibroids. Usually it is indicated in those who are symptomatizing, large size or recurrent, and this entails the surgical removal of the uterus, including the leiomyomata. But the myomectomy is an alternative to surgical approach in which the myomata are removed alone and the uterus is preserved, and this is suitable for young patients who need to preserve their fertility and still need to have children. The indications of the surgical removal of leiomyomata, whether myomectomy or hysterectomy: whenever I'm having a large size myoma, whenever the myoma is causing a severe symptom, severe bleeding, whenever there is intervening with the conception, recurrent abortion, infertility, or interfering with a planned IVF procedure, whenever there is a suspect of malignancy, rapid recurrence after removal, rapid growth or appearance for the first time in menopause, whenever I'm having a submucous fibroid protruding from the cervix because in a way or another it would end up in infection or bleeding, whenever I'm having a large cervical or a broad ligamentary myoma affecting the urinary condition. The myomectomy is preserved for those who are young in age and desire future fertility or seek preservation of the menstrual cycle. It can be done through an abdominal approach, open myomectomy, and that's the standard procedure. But in case of sub-serous myomas, it can be of small size, can be done laparoscopically, and those that just a single submucous myoma, it can be done through a hysteroscopic procedure. The aim of procedure is the surgical inoculation of a myoma from the myometrium while preserving the uterus. Its advantage is to alleviate the symptoms. It improves the symptoms, the bleeding, the pain, the mass, the infertility, preserve the future fertility, and resume the normal menstrual function. The indication: we're never having a large symptomatic fibroid in a patient who desires to preserve her fertility and the menstrual function, whenever it's even after the childbearing period is completed and the patient prefers uterine conserving the uterus. The fibroids, those who cause infertility, we mentioned that the myomata leading to corneal tubal block or a submucous fibroid, or if the patient is presenting with recurrent pregnancy loss secondary to submucous fibroids intervening or interfering with the implantation. The contraindication: after menopause, the patient has completed the patient has entered in the menopause, so there is no place to conserve the uterus, or premenopausal, in the climacteric period, which is near menopause. During pregnancy, we don't proceed to myomectomy during pregnancy because of the increased vascularity and the increased risk of bleeding. At cesarean section, only if we only do myomectomy if it interferes with the uterine scar, or if it's a pedunculated myoma, you can do myomectomy because we do become afraid of the uterine torsion and the perforeum. And if we're suspecting a malignant change, you don't do myomectomy, you proceed to hysterectomy. The complications of myomectomy actually is that blood loss at this operation is much more serious than a hysterectomy. It's a bloody operation. There are high instances of post-operative fever, anemia, pain, and there is what's known as persistent or recurrent menorrhagia. And even after removal of the myoma, the patient still complains of heavy menstrual bleeding, whether persistent, it it hasn't alleviated at all or recurred after a certain period of time, and this is probably due to recurrence of the myoma, or even without the recurrence of the myoma, due to associated endometrial hyperplasia, an increase in the vascularity, an increase in the endometrial surface and the myometrial blood vessels. Recurrence of fibroid may occur in up to 30% of the cases, the risk of post-operative adhesions, and the risk of a ruptured uterine scar in subsequent pregnancy. That's the procedure of abdominal myomectomy. You will do an incision, inoculate the myoma, and then you will suture the uterine and you will suture the myomata bed. That's the image of the gross picture of myomas after removal. The Bonney's hood operation is to avoid a posterior wall incision, is to do a transverse incision and inoculate the myoma, and then as if you are doing a hood to get to make the sutures anteriorly to avoid the risk of uterine post-operative adhesions. Laparoscopic myomectomy. Hysteroscopic myomectomy, using the resectoscope to enter inside the uterine cavity and remove the myoma using the resectoscope. What about hysterectomy? Hysterectomy means surgical removal of the whole uterus, including the leiomyomata. It's indicated in postmenopausal women with symptomatic or large fibroids, in premenopausal women who have completed their family, and whenever the myomata are so large and multiple, making myomectomy a very risky procedure. The advantage is that that's a definitive treatment and will lead to relief of the symptoms. There is no risk of recurrence, and it leads to less blood loss and less post-operative morbidity. This advantage that there is loss of the future fertility and there no longer menstruation after removal of the uterus. It can be done either through an abdominal approach, whether total or subtotal. The difference between total and subtotal hysterectomy is the removal of the cervix. Total abdominal hysterectomy is you remove the body of the uterus and the cervix. The subtotal hysterectomy is removal of the body and preserving of the uterine cervix. Vaginal hysterectomy can be done for small myomata. It can be done through vaginal approach, and it can be done through laparoscopic approach. Thank you.